Thank you very much. I would like, first of all, to express my thanks to Professor Kotsis for this kind invitation, and also to express my thanks to Professor Savopoulos, who chairs this roundtable. The topic of my presentation is how to treat a 70-year-old hypertensive patient after acute stroke. And these are my financial disclosures. We'll go straight to the case presentation. We have a 70-year-old hypertensive man arrived at the emergency department at 9:15 in the morning, with speech difficulties and weakness of the right side. He had awakened that morning without symptoms, and during breakfast at 8 a.m., his wife reported that the patient was unable to speak and could not move his right arm or leg. She called 911 and he was transported to the emergency department. Computed tomography was made of the brain, so no hemorrhage and no early ischemic changes. His blood pressure was 170/100 millimeters of mercury, and platelet count, glucose level, and prothrombin time were all normal. After the patient returned from imaging at about 10 a.m., a neurologist confirmed the presumptive diagnosis of acute ischemic stroke and recommended immediate initiation of intravenous thrombolytic therapy. This presentation is going to be divided in three sections. What we call the hospital management, the acute care and secondary prevention. And I'm going to, we know that most recently, last year, the European Stroke Organization has published some guidelines on blood pressure management, especially in acute ischemic stroke, but also in intracerebral hemorrhage. With regard to the hospital management, the first question is how about lowering the blood pressure in the hospital setting? Actually, before the patient arrives to the hospital, do we have any data on this question? We have at least 4 trials who have tested this question. Actually, it was the RIGHT and the RIGHT-2 studies in 2013 and 2019. And actually, it was not found any difference in mortality and in functional outcome at 3 months. And another 2 studies, one used magnesium sulfate in the hospital setting, and again, at 3 months, there was no difference in functional outcome or in mortality. And the last study used lisinopril, and again, there was no difference in mortality between the 2 groups. So the European Stroke Organization guideline suggests against the routine blood pressure lowering in the pre-hospital setting in a patient with acute stroke. Now going to the acute care. The acute care, especially in patients not treated, I mean, we are not eligible for intravenous thrombolysis or thrombectomy. Should we lower blood pressure in these patients? We have a lot of information about that. We know that from the past that elevations in blood pressure over 140 and over 160 actually are detected in the majority of patients with acute stroke. And we also know that both elevated and low blood pressures have been associated with poor outcome after stroke. Dr. Vermos has showed in the past that blood pressure admission and mortality are associated with what we call U-shaped curves. And this is true both for systolic and diastolic blood pressures. We have at least 5 studies that have tested the lowering of blood pressure in the acute setting, in the acute care. It was the VISTA, the CHIPS, the COSACs, the SCAST, and CATIS trials. All these trials actually showed no significant benefit, either on cardiovascular endpoints or functional outcome by lowering blood pressure in acute ischemic stroke. And actually, on the contrary, early administration of antihypertensive treatment and, of course, the intensity of blood lowering were associated with early deterioration, poor neurological outcome, or even death. The most recent meta-analysis actually, which included almost all studies testing the effect of blood pressure lowering on mortality and on functional outcome, there was, as you can see here, there was no difference in mortality at 3 to 6 months in these patients, and also there was no difference in functional outcome on these patients. So the recommendation is that in patients with acute ischemic stroke and blood pressures that they are lower than 220/110, who will not be treated with thrombolysis or metallic thrombectomy, the suggestion is against the routine use of blood pressure lowering agents, at least in the first 24 hours, unless, of course, there is necessary for another specific comorbid condition like acute pulmonary edema or rupture of an aortic aneurysm or something like that. Also, there is an expert consensus statement, and in these patients in whom there is a very high blood pressure, higher than 220/120, it is suggested to have a reduction of up to 15% for the systolic blood pressure, and this should be reasonable and likely to be safe. There is no suggestion about which agent to use for lowering the blood pressure. Now, moving to patients who are treated, who are eligible for thrombolysis or thrombectomy, and we know that there are certain thresholds in order to give to a patient with acute ischemic stroke a thrombolysis. We know that systolic pressures of over 185 and diastolic over 110 are contraindication actually to give intravenous thrombolysis. And this actually has been based on the protocol from the original study in 1997 from the NIH. We don't have randomized data to support actually this recommended blood pressure threshold, but both the American Stroke Association and the European Stroke Organization endorse these thresholds. And in addition, there is appropriate concern that aggressive blood pressure reduction may reduce viable penumbral tissue, result in expansion of the cerebral infarction, and contribute to neurological deterioration. But on the other hand, it has been shown that elevated blood pressures before or during the intravenous thrombolysis may be related to a higher risk of symptomatic intracerebral hemorrhage and a lower 3-month functional outcome. So, a very large meta-analysis that was published in European Heart Journal in 2017, which included more than 300,000 patients with an ischemic stroke, of who about 80,000 received thrombolysis. It was found that there was a J-U-shaped relationship between blood pressure and outcomes, as you see in the next slide. You see that mortality was related related to systolic, diastolic blood pressure, mean arterial pressure, and pulse pressure with either J or U-shaped curves. And however, the risk of hemorrhagic complications of thrombolytic therapy was higher with higher systolic blood pressures and lower with lower systolic blood pressures, meaning that the lower the blood pressure, the lower the risk of hemorrhagic complications, but on the other hand, the higher the risk of hemorrhage in these patients. The best actually trial who tested the blood pressure lowering in patients with who are eligible to thrombolysis was the Enchanted trial. It was published 3 years ago in Lancet. It included more than 2,000 thrombolysis eligible patients. There were 2 targets: the intensive target of 130 to 140 millimeters of mercury, and the guideline recommended that the target was lower than 180 over the 72 hours. You can see here that the mean difference in the first hour that was achieved was only 7 millimeters of mercury. From that trial, it was not found that there was any significant improvement in functional outcome, but there were fewer intracranial hemorrhages in the intensive group. So as we said before, the lower the blood pressure, the lower the risk for intracranial hemorrhage. The strange thing with this trial was that in a post hoc analysis of this trial, despite the fact that we had, as we said before, lower incidence of intracranial hemorrhages, the intensive blood pressure lowering group was associated with increased 3-month mortality. So, in patients treated with thrombolysis or with thrombectomy, what are the recommendations? The recommendations are again the same as it was before. We should not start the intravenous thrombolytic agent unless the blood pressure is lower than 185/110 before the bolus, as we said, and we should keep the blood pressure lower than 180/105 and for at least 24 hours. And also there is a suggestion not to go too low with systolic blood pressure, and that it's better to avoid the target of 130 to 140, and it's better to go just lower to 180, meaning the conservative or the standard treatment, as we said. Now, should we increase the blood pressure in these patients? If the blood pressure of a patient with acute stroke is low, should we give any medications or any other agents to increase the blood pressure? Do we have there? We don't have a lot of data on that, and but the suggestion is against the routine use of vasopressor drugs to increase the blood pressure. And there is an expert concession statement, of course, in which in circumstances where there is a hemodynamic mechanism in such patients, it should be better to stop the blood pressure lowering therapy, to administer, of course, intravenous fluids, and in case that the blood pressure does not, we cannot succeed to increase the blood pressure, then we can use a vasopressor agent to increase the blood pressure with close monitoring. Stopping or continuing antihypertensive treatment in these patients. We have 2 studies in that field, the COSACs in 2010 and the IMUS in 2015. There was no difference either in mortality or in functional outcome at 3 to 6 months in patients continuing or stopping the blood pressure lowering treatment. So the suggestion by an expert consensus is to stop the previous oral blood pressure lowering therapy in patients with dysphagia or anterior swallowing is restored or a nasogastric tube is in place. So for patients in the acute care, routine blood pressure lowering is not recommended. In patients who are eligible for thrombolysis, as we said, we should keep the blood pressure lower than 180/105 for at least 24 hours. And if there is another reason, or if the blood pressure is higher than 220/120, then we can give some antihypertensive agent to reduce the blood pressure by up to 15%. And now going to the secondary prevention, we know that when we have a patient who has initial stroke, ischemic stroke, or a transient ischemic attack, the annual risk of a subsequent or as we call secondary stroke is approximately 3 to 5% per year. It's a very high percentage, and of course we know that the risk of recurrent stroke is heightened by the presence of elevated blood pressure, and it has been shown from the past that antihypertensive treatment has been linked to a reduction in 1 year recurrent stroke by approximately 30%, a very high percentage. So it's very important to lower the blood pressure in these patients. And the first meta-analysis is back to 2003, in which 7 randomized trials were included. You will see here the HOPE study and the PROGRESS study, which used ramipril and PROGRESS used perindopril along with edaravone. And what was found from this meta-analysis, as I said, the Hope and Progress studies were the major studies. It showed that there was a reduction for recurrent stroke about 24%. Then it was the PROFESS, the PROFESS study, and the Transcend, the sister study of PROFESS, it was the Transcend study. And when they combined, we combined the data from these two studies, again, there was a 15% risk reduction for a recurrent stroke with lowering the blood pressure. And in two meta-analyses that were done after that, it was shown again that there was a risk reduction of 30%, as we said in the beginning, and another meta-analysis showed a risk reduction for stroke, for recurrent stroke, about 22%. These meta-analyses, the latest meta-analysis, I mean, after the first meta-analysis in 2003, that these meta-analyses were done in 2009, and it included also PROFESS, as you can see here in Transcend. So we know that the risk reduction is very important when you lower the blood pressure after an ischemic stroke. But what should be the blood pressure target? The first, the major study who examined that was the PROFESS study, and it was found from the PROFESS study that the lower risk for recurrent stroke was observed at systolic blood pressure levels ranging from higher than 120 to lower than 140, between 120 and 140 millimeters of mercury. The SPS3 study also examined that effect, in which it was found that there was a reduction, risk reduction for recurrent stroke because of reduction of intracerebral hemorrhages. And the largest actual meta-analysis who has tested the blood pressure targets is a Greek study in which author was Dr. Maria Pipilidou, who's going to comment later on. And it included 14 studies with more than 40,000 patients. And it was compared the intensive treatment with the target of systolic blood pressure lower than 130 versus the conservative, that was the systolic blood pressure between 130 to 150. You see all these 14 studies here. And what was found that there was a significant 27% risk reduction for recurrent stroke, for disabling or fatal stroke, and for cardiovascular death. And also that when you had, it was better to have a lower blood pressure, lower than 130 versus higher than 140, and also for the diastolic, lower than 85 compared to higher than 90 millimeters of mercury. After this large meta-analysis, 3 randomized controlled trials were included in a Cochrane analysis, in which, as you can see, in this Cochrane meta-analysis, again, it was found that there was a 20% risk reduction with the intensive treatment compared to the conservative one, meaning lower than 130 millimeters of mercury. And the most recent trial which tested the blood pressure target was the RESPECT trial in JAMA. And when RESPECT trial was added to this meta-analysis, you see that there was a 22% risk reduction in the intensive treatment compared to the standard treatment. So, what is the recommendation is that after a stroke or a transient ischemic attack, the blood pressure target should be the range of 120 to 130, and in patients who are older than 70 years old, lower than 140 down to 130 if tolerated. And I will finish with is there any preference for which antihypertensive agent to use after a stroke? From the past 2003, it was diuretics and RAS blocker who were better than the other medications that you see here. Another meta-analysis 2016 showed also the same results, that the combination of diuretics and RAS blockers and diuretics themselves were better than the other antihypertensive class drugs. And in this large meta-analysis, as I said before, in that meta-analysis, almost all antihypertensive drug classes were included. You see, antiadrenergic drugs, beta blockers, calcium channel blockers were not better than the others. And again, the better results we had with thiazides, diuretics, along with the combination of thiazides with RAS blockers. So, about secondary prevention, in hypertensive patients with an acute ischemic stroke, antihypertensive treatment is recommended immediately for transient ischemic attack and after several days after an ischemic stroke. The target should be at the range of 120 to 130 force is tolerated, and the agent to prefer is a RAS blocker plus a thiazide or a calcium channel blocker. Most recently, the American guidelines were published as well, in which there is an agreement between the agent we preferred, the thiazide and the RAS blocker, or the combination as you see, and the goal should be at the range of 130/80, lower than 130/80. What is most important and should be noted is that the magnitude of blood pressure lowering appears to be more important for risk reduction than the class of antihypertensive agent used. And concluding, the degree of blood pressure reduction is linear and positively associated with the risk reduction in recurrent stroke and cardiovascular events. And besides the fact that the optimal blood pressure limits, cutoffs, and walls in different patient groups may still be debated, strict and aggressive blood pressure control to normal tension in patients with ischemic stroke and transient ischemic attack is essential for secondary stroke prevention. Thank you for your attention.